Good evening, everyone, and welcome to our Screenside Chat with Dr. Carla Greenbaum on TrialNet. I'm going to wait a couple of minutes because our attendees are joining the webinar. I'd like to thank all of you who are taking time on this Sunday evening or afternoon, depending on where you live, and spending some time with us. I'm Jeff Hitchcock, the president and founder of Children with Diabetes. We are an organization that provides education and support for families living with type 1 diabetes. I'm going to wait just another couple of minutes and we will get going here. I think the entrances have slowed, so why don't we get going so that we can get everyone back to their families after this wonderful Screenside Chat. So as I said, this evening's chat is on TrialNet, and we have Dr. Carla Greenbaum with us. She is the director of the Center for Interventional Immunology at the Benaroya Research Institute in Seattle, Washington, which is why you still see the sun behind her window. She's a clinical investigator who focuses on the natural history of type 1 diabetes, specifically with prediction of disease and interventions to alter immune-mediated beta cell function. She has conducted studies evaluating beta cell function and other physiological and immune changes that occur during the progression of the natural history of type 1 diabetes. She currently serves as the chair of Type 1 Diabetes TrialNet, an NIH-sponsored international consortium conducting multiple clinical trials in type 1 diabetes. And she is a very good friend of Children with Diabetes, the organization, and our families. And with that, what I'm going to do is turn it over to Dr. Greenbaum. If you have questions during this chat, feel free to use the Q&A feature. I will also be watching the chat. We have Carrie Sparling of CWD in the background. She'll be assisting in the chat also. After the presentation, we'll pick up on the Q&A. Dr. Greenbaum, it's all yours.
Terrific, and thank you so much for the opportunity to talk with you all. Thank you, Jeff and Carrie and the rest of the CWD team, which is really does such a wonderful service for everybody in the type 1 community. When I'm trying to get going here in a sec, I'm going to show some slides, but there'll be plenty of opportunities really to chat as needed as before we're done for this afternoon. I'm going to introduce a little bit about where we've been going, where we've been, and where we're going to be going in TrialNet. And I know that many people on this call have already participated, but hopefully you'll still learn something new about what is going on with TrialNet. And what I'm going to cover is what is TrialNet and how does it work? And then third, a very important part of this presentation is how you can help advance curing and preventing type 1 diabetes. At the very end, I have a quiz, so you have to pay attention to see if you could answer the quiz. Fundamentally, what is TrialNet? It's an international research consortium. There are hundreds of clinical sites and a lot of other pieces that make it work. There's central laboratories, a data center, etc. And we're funded primarily by the NIH, that is US tax dollars, and a large proportion of that comes from the Special Diabetes Program that Congress appropriates every several years, and many of you might have been lobbying Congress for that money. So TrialNet is a big recipient of congressional award. But what else is TrialNet? It's researchers, which are people like you, who have a passion to stop type 1 diabetes from all over the world. And our mission is to prevent type 1 diabetes and stop disease progression by preserving insulin production before and after diagnosis. Or in other words, we're here for saving beta cells as much as we can at any time in the disease process. And fundamentally, our name is our mission. TrialNet is really all about doing clinical trials so that we can bring new therapies for people to use to prevent diabetes. So how does it really work? Hopefully many of you have at least seen our TrialNet ribbon or the path to type 1 diabetes. And I want to take a minute to explain it, partly because many people think it's a cute design, but don't necessarily understand what we meant by some of the different steps that we put in here. So I'm going to take a minute to walk through how we think about the path to type 1 diabetes. It turns out that everybody who eventually gets diabetes has some genetic risk. And we know that for many reasons because we can study a lot of the different genes. But importantly, we already know this before we had the technology to study the specific genes because we knew that it was more common in people that had a relative. So that if you do have a relative, you have a 15 times greater risk of getting diabetes than if you had nobody in your family. And since you share your genes with your family members, this really highlighted initially many years ago that genes were important in diabetes. But as you can see this step down from genetic risk to the next step. And that's because the vast majority of people who have genetic risk will not develop type 1 diabetes. So something happens to a smaller subset of people with genetic risk in which the immune system is activated. And only in a certain proportion of those people does the immune system respond. And in general, the immune system often responds first with the development of a single antibody. An antibody is just a marker that the immune system has been turned on. Of course, we've all been talking about antibodies in the age of COVID, but this is a different type of antibody. This is an antibody to yourself, to your own body. That's what autoimmune disease is all about. But not everybody who has a single antibody will then progress to the next step, which is having multiple antibodies. But as you can see here, once you have multiple antibodies, we believe that the vast majority of people will continue on through these different stages until you get clinical diabetes. So we call this stages of diabetes, where stage 1 are people that have multiple antibodies and blood glucose is still normal. Stage 2, multiple antibodies, the blood sugar is not quite normal anymore. And then finally, stage 3, or what we would commonly call so-called new onset diabetes. So I hope you understand more about how we have these step downs in the ribbon to really emphasize it's when you have multiple antibodies that suggests that over time, virtually everybody will continue to getting clinical diabetes. So how does TrialNet work? Well, it really starts with our Pathway to Prevention study. And what that is, you might want to think about it as a funnel. It's a funnel to trials. So we screen or test a lot of people for the presence of antibodies. And depending on the results and the different measures, this is how we identify people that we put in trials to see about preventing diabetes. Hopefully, many of you on this call already know about the most important study that has been released in the last year. And this is the teplizumab prevention trial. The people that participated in this trial came from the Pathway to Prevention study. They were screened, they were found to be at risk, and they agreed to participate in this trial. And it was by their participation that we had this astounding result announced in June of 2019, in which we found that the people who received the active drug had an average of 2 years of delay in getting diabetes. And as we continue to follow some of the participants that were in the study, it now seems that the average delay is up to 3 years. So this was a pretty important difference. Of course, all of you on this call who are living with diabetes, who have a family member with diabetes, it's pretty easy to convince you that a 2-year delay would have made a big difference in your life. What else about that study that's important for you to know? There were 76 people in this study. The vast majority, 3/4, were children that were enrolled in that study. One of the ways I find useful to look at the results that one of my students suggested is this way. This is the number of people in the study who got placebo. That is, that we did not have the active drug. And this is the number of people that got the active drug. And then we followed them to see what happened over time. And within the first year, 3 of the people who had received the teplizumab progressed to getting diabetes. But you can see way more people who had not received the active drug progressed to diabetes. This is a pretty dramatic way to show how important this result has been. So this is a really big step. From my gray hair, you can recognize I have been studying and trying to see about how we can prevent and delay diabetes for something like 35 years. And this is the first study ever to demonstrate that the onset of diabetes could be delayed. For those of you that aren't as old as me, may not recognize the Apollo landing, but that was a pretty darn big step too. I think it's pretty similar. But one trial and one drug is not enough. This study studied only 76 people, 44 receiving the active drug, and should have been 32 on placebo. But like all therapies, not everybody who got the drug benefited. And so what we really need now, more clinical trials so that we'll have more therapies and we'll have more choices as things go eventually to market and people can use them in clinical practice. Everybody on this call surely knows that one option isn't good enough. If you only had one insulin and one type of pump, and you couldn't use multiple injections and your insurance didn't cover it, you know the problems, right? The key here is we want to have multiple options for people because we know that we can delay or prevent the diabetes in a lot of people with different kinds of therapies. And we know that this is the same ribbon that I explained to you before. And what I'm highlighting here is that teplizumab was first studied in people that had clinical diabetes, that has overtly new onset disease. And it was when the drug looked like was beneficial in that group that we chose to study it earlier at stage 2 diabetes. So we took a drug that was shown to work in new onset, and we then tested to see if we could prevent or delay diabetes. That's how that trial started. So the news that may be new to you is that there's not just one therapy that is effective at stage 3 or new onset diabetes. In fact, there are 7 therapies that can change the disease in people that are new onset. There have been dozens and dozens of trials with different types of drugs that have been tested in new onset. It's not like everything will work in people that are clinically diagnosed, but now we know there are at least 7 different therapies that are effective in changing the disease course in new onset. So it's pretty obvious. What do we want to do next? TrialNet wants to study them earlier to see whether these other drugs, just like teplizumab, can also delay or prevent diabetes. If we can demonstrate that's true, there are more choices and more possibilities for people to benefit eventually. Now, this is one way that we identify different drugs that we're going to do early on and to see if we can delay or prevent diabetes. And I highlighted this one in yellow of abatacept because that trial is all finished recruitment. We'll have the results of that trial before the end of 2021. But in addition to testing drugs because they were positive in people that already had disease, we also can test some drugs because of other reasons why we think they might be beneficial to prevent or delay diabetes. And we are currently running another trial with hydroxychloroquine, and I'll show you some of that information in a moment. So let's review a little bit. Pathway to prevention is this big funnel, and the first step of that funnel is to be screened, and screening is really there to determine your antibody status. Now, in recent months, we've gotten a lot of questions about understanding a little more details about screening process. And so I've got 8 frequently asked questions for people to think about. First, who is it that's eligible to be tested in TrialNet? And those are relatives of people with type 1 diabetes. Second, what are the ages of people that can be tested? If it's your immediate family, so-called first-degree relatives, children up to about 2.5 to 45, and other relatives from age 2.5 to age 20 can be tested under TrialNet for the presence of antibodies. How do we collect the blood? Particularly in the age of COVID, we can do it at home. You could sign up and register online, give the consent, receive the kits in your home. You'll get a way to have FedEx pick up that sample from your house. You won't have to leave your home, and you can get tested at home via this finger stick. However, for people that would prefer it, we also have the option for going into a TrialNet center or other clinical lab to get a blood test. But again, we can do both home or regular blood tests now. And in fact, during this past year, more than 60% of the people tested have chosen to be able to do this at home. So what antibodies does TrialNet test? Well, we test up to 5 antibodies. 4 different ones here are called GAD, IA2, insulin, and zinc. And then one ICA uses a slightly different test. Now, we don't test all 5 antibodies on the first sample that you give us. We first test for 2 of the antibodies, and depending on those results, we decide whether to test with the other ones. This is the most efficient way to identify people who have multiple antibodies, because that, after all, is the goal, because those are the people that are going to be getting diabetes. Those are the people that we want in our studies. Question 5. What is the cost for TrialNet screening? It's free. Well, it's actually your tax dollars, but it's free for you to participate in the study. What about privacy? Because this is conducted as part of a clinical trial, there are very strict rules and regulations about keeping that information private and not sharing that information with anybody else. What support can you expect? You can expect that you have personal and ongoing contact with TrialNet experts that have been involved for a long time in the prediction and prevention of type 1 diabetes. We know that if you're found to be antibody negative, that could be a great relief. But for those people that are found to be antibody positive, that's something that requires somebody who understands the disease and the process and could support you as you continue on and provide you with the information about potentially participating in trials. So what's the next steps? You can have, as I mentioned, free and ongoing monitoring to see whether your disease is progressing, and you have the option to enroll in a TrialNet prevention study if we have one that's open to you. Now, the other question I get a lot when I talk about TrialNet is, why does TrialNet just focus on screening relatives? We know that most people, when they get diabetes, did not have a relative when they got the disease. And the answer goes to our first sentence and in our name. We are TrialNet. Our aim is to do clinical trials. And the fastest and most efficient way to do more trials is to screen relatives. So I've got a little bit of math here, but I made it visual, so it should be pretty clear. In general, if I'm screening relatives, I would need to test 50 relatives to find one person who has multiple antibodies, who, as I mentioned before, is very likely to get type 1 diabetes and is the people that we are most interested in finding to potentially enroll in clinical trials. So again, we'd test 50. I would find one person who would have multiple antibodies to be in a trial. I would have to test 750 people for antibodies to find one person who has multiple antibodies who did not have a relative. So as you can see, it's a lot more efficient to focus on testing relatives. Even though there are so many people that I can test, I will still find people who have multiple antibodies who will go on likely to develop type 1 diabetes. So one of the things I want to make sure everybody understands in this call is that we think about this as more is more. Anybody that is identified as having multiple antibodies is eligible to being in TrialNet studies. We have an open door policy. So if you were identified as being multiple antibody positive, you can be part of TrialNet, whether you were a relative or if you were screened through some other way and found that you have antibodies. Our aim is to find people who are at higher enough risk to be in clinical trials. As I mentioned before, the next step for people that are found to be antibody positive is the monitoring. So once people are antibody positive, the idea here is to provide support to you as you learn where you are on the path to type 1 diabetes. We allow you to see if you're eligible for your clinical trial. It allows us to identify if you are progressing. We can prevent ketoacidosis through regular monitoring and connection with the TrialNet experts. Importantly, you're really contributing to the future. Every participant, the data and the information that we have leads to the next generations of therapy which continue to improve as each year goes by. And the third part then of this funnel is the people would then be identified who would be eligible for a trial. And your eligibility depends on your age and what trials happen to be open and what medications there are, but you get to choose whether you want to participate in a trial. As I mentioned before, more trials, more choices, more benefits. To stop diabetes, we need to do these prevention trials, and that means we need a really big funnel. How can you help? Well, the more people screened will increase the number of people in monitoring, which increases the number of people who are eligible for a trial, which means we can conduct more trials faster. So where are we going? What are the trials that you're likely to be seeing? Of course, what we want to do is build off the success of the current trial of teplizumab, in which we delayed the progression of diabetes, and do more studies. But you may be wondering, how do we decide what studies to do? There are so many different therapies potentially to think about. And I would say we think about it in 3 buckets. 1, we want to test, potentially when available, new and novel therapies. 2, we want to test therapies that have worked effectively in people living with other autoimmune diseases. And 3, we also want to test the therapies that we've shown to work in people that are newly diagnosed, as I mentioned to you before. So to focus first on using new and novel therapies, we have a study we've just launched called the TOPL Type 1 Diabetes Study. This is really testing a brand new designer drug. It was designed by Novo Nordisk specifically to stop diabetes. And these are my designer togs I lifted from the internet. Trust me, I never wear designer clothes, but it looked cool. But this is a designer drug. It was made specifically to see if it could stop diabetes. It uses something we term a plasmid. A plasmid is just a circular piece of DNA. All it does is a delivery vehicle. It's like a truck who ships packages to different locations. It packs the DNA into the cells where it communicates with your immune system, and your immune system says, hey, I need to use this to turn off the beta cell attack. So this is the study that we're doing now called the TOPL study, a brand new drug. Because it's a brand new drug, this current study is what we call a phase 1 study. A phase 1 study is only testing whether the drug is safe and tolerable. In other words, we won't know when we complete the study whether the drug was effective in saving beta cells, whether it works, but it will tell us whether or not it changes the immune response in the way that we want it to do. Adults who are up to 4 years from clinical diagnosis can participate in the study, and there's 12 weekly injections in the study. So that's what the current study is. It's the results of these studies that will lead to the future study, which is really asking, can it then work to delay or prevent type 1 diabetes? So this is the example of the first category of how we choose therapies to test, new and novel therapies. The next category then are therapies that worked in other autoimmune diseases. And here I have a picture of a reflection on how similar many of the autoimmune diseases are. They all have very many things in common. Many genetics are similar between people with different types of autoimmune diseases. And we know that therapies are likely to work in one disease, may also work in others. So this is our aim to test, will they also prevent diabetes? An example of this is the current hydroxychloroquine trial. We're not testing it for any reason related to COVID. We're testing it because it has been used for almost 50 years to treat people that are both adults and children down to age 2 with arthritis. It may also slow progression from early and mild arthritis to worse symptoms. It can also, so we are asking the question whether it can slow progression from stage 1 to stage 2 diabetes. So who's eligible for this study? Again, they are people that were identified through the Pathway to Prevention study, who have multiple antibodies, normal glucose, and are at least 3 years of age. As I noted before, these are people we consider with stage 1 diabetes. The treatment is either receiving the hydroxychloroquine by mouth tablet or placebo. And we already have more than 200 people enrolled, both before and the same child after COVID started, where people can still come in and safely participate in research studies, even during the pandemic. And as I mentioned before, our third category of how we choose trials is therapies that have worked in newly diagnosed people with diabetes to see whether they would prevent diabetes. I've mentioned that the teplizumab study several times caused a delay. The abatacept study, which is another drug, was effective in new onset. We've completed enrollment and we expect the results at the end of this year. We now have 3 other trials for therapies that have potentially worked in new onset that we want to test to see if they can work in prevention. Which then leads to me to the third part of my talk, which is how can you help? I want you to consider to be a TrialNet ambassador. And to be an ambassador, you have to be able to answer these 3 key questions. First, what is TrialNet's mission? Stated simply, it's to stop diabetes by saving beta cells and prevent it. How does pathway to prevention lead to trials to stop diabetes? Pathway to prevention is the funnel where we find people who are at risk to enroll in trials. How can people connect with TrialNet? TrialNet.org. A few drops can make a big difference. How can you help? As I noted at the beginning, I'm sure many of you on this call and your family members have already participated in TrialNet. If you have, then I want you to be sure that everyone you know with diabetes knows that their risk for their family members, that the path to cure for type 1 requires the trials, and that's what TrialNet is all about. If you haven't participated, I hope you will consider doing so. A question I got previously was, how much impact can I have if I talk to people who I know who are living with diabetes about participating in TrialNet? Now, you remember I mentioned to you, for example, there is at least 7 therapies that are very effective in newly diagnosed diabetes. We want to test them all to see whether it can prevent diabetes. To test more and to do those more quickly, we need people to participate. So let's just do a math problem here. If there are 40,000 people newly diagnosed with diabetes each year, let's just say on average there's 3 other members of their family, that means 120,000 people could be screened each year, which would give us 3,000 multiple antibody positive people eligible for trials every year. I already told you the teplizumab trial had less than 80 people. Just think how many trials we could complete if we had everybody stepping up to the plate. And then if you think not about the people that are newly diagnosed, but the people that are living with diabetes, maybe there's 1.5 million. Maybe they have 2 eligible family members. Again, this gets to 3 million people to be screened and 75,000 people who could potentially contribute to helping us stop type 1 diabetes. So I'm going to turn now to the quiz. I hope I haven't been talking too fast. We'll see if we have time. We'll go through the quiz here. So what is the risk in relatives as compared to the general population? I want you to all just take a few minutes and answer this question in your own head, or if you're sitting with someone, see what you think. Is the risk 3 times higher? Is there no difference once you have a relative? Or is the risk 15 times higher? Tick tock, tick tock, tick tock. Here's the answer. The risk is 15 times higher. Next question. Why should people get involved in TrialNet? Is it A, for trials, B, for reassurance, support, privacy, and ongoing monitoring, or C, to be part of the solution? This one's a giveaway. The answer, of course, is all of the above. How does TrialNet find people for prevention trials? Is it A, Do we screen relatives for antibodies through the pathway to prevention? Do we put people who are not relatives who are having antibodies? Or do we find people for prevention who are living with type 1 diabetes? This is your trick question, you know, the one you always hated your teacher doing. But the answer here, of course, is it's people who don't yet have diabetes that we put in prevention trials, whether they are relatives or people who are not relatives who are found to have antibodies through other testing programs. But it does emphasize it's people living with type 1 diabetes that really have the burden on their shoulders to let others know, people that they know that are living with diabetes and their own relatives, about their risk, and let them know that TrialNet has that screening options. Now, how many different therapies have been already shown to change type 1 diabetes at new onset or stage 3 disease? Is it 1? Is it 20? Or is it 7? Tick tock, tick tock, tick tock. On this answer, the answer is C, or 7. 7 therapies we know are effective to delay further beta cell destruction in newly diagnosed diabetes. How much does it cost to get antibody screening and monitoring in TrialNet? This is kind of a giveaway too. There's no charge to participate in TrialNet. Where should you be directed to get screened? A pretty easy one. TrialNet.org allows people to get all the information that you need. It provides you links and contacts with people if you have additional questions. It allows you to sign up and register online and receive a kit, all through our website. So that was the end of my formal presentation, but I'm very happy to spend some time answering questions if there have been some, or any other clarifications. Thanks so much for listening.
Thank you very much, Carla. We have one question, and I have some, but let me bring in the question from one of our attendees. States, I know not all persons with T1D have antibodies. What's with that? Why do they have T1D, and are they ineligible for studies?
That's a terrific question, and I'm going to give you a little history here. So the first antibody that was first described in the early 1970s was islet cell antibody. It was about a decade later before we identified insulin antibodies, and another 10 years after that before GAD was discovered, and 10 years after that, IA2, and finally the zinc antibodies. So as science marches on, sometimes we can identify antibodies that we didn't know about or couldn't test beforehand. So if you were tested when in 1990, we wouldn't have tested for these other antibodies. You would have been thought to be, quote, antibody negative, when in fact we now could test you and you might have them. So that's the first thing. Secondly, yes, it is true that there will be some people, even if all 5 antibodies were tested and they have clinical diabetes, will have none of those present, even though they look like they have type 1. That is, they need to take insulin to control their blood sugar right away. Well, there's 2 possibilities as to what might be going on there. One, there may be some antibodies we haven't yet discovered that that person would react to. But at first, we only think there's less than 5% of people that would fall into that category. So that's unlikely. What we now know, because of all the wonderful new science that has gone on, is that there are a lot of people, not a lot, but there are some people who otherwise look like they have type 1 diabetes. If they have no antibodies, it's possible that you have a rare genetic form of diabetes that's not type 1 diabetes at all. So I think if that happens, you might want to talk to your clinician about doing some testing for genetic tests. It's a long answer to a simple question, sorry.
No, but what you've shown is it's a complex question.
Yeah.
Simple question, complex answer.
Yeah.
So we have a question in the Q&A. TrialNet used to screen once a year, but no longer does that. Will this ever change? How often in the past did someone test negative and then a year later test positive?
Terrific question. Thank you for that, because when we made those changes, we didn't have as much opportunity as we would have liked to communicate clearly as to why those changes were made. So the first answer is that when you, as I mentioned to begin with, about 5%, so 5 out of every 100 relatives that we test first time will have at least one antibody, right? Half of those will have 2 or more antibodies. And TrialNet is all about identifying people with 2 or more antibodies. So 2.5%, or 2 to 3 people out of 100 that we test the first time around will have multiple antibodies. If we retest them, it's less than 100th of that. So it's very unlikely on the retesting to be having multiple antibodies. It doesn't mean you won't have one antibody, but the risk for multiple antibodies is very low. This is not the answer though, right? This is not the final word on this, because one of the things that we hope to do, we use all the information we gather in TrialNet to say, well, maybe we still should test maybe once every 4 years or once every 5 years. And we don't have the answer to that question yet. But on the work that was done when we first changed the protocol, the risk was so low that retesting was not really warranted.
Makes sense. So here's a question that I get asked a lot, and it's how do you talk with parents and encourage them to have their children screened? For example, parents who are living with type 1.
Yeah. Listen, it's kind of a scary thing, right, to think about. I mean, it's one thing if you were thinking about being in research for yourself, it's very different to think about putting your child in research. And you're probably just really scared to see what that answer is, and you might feel guilty, right? You have diabetes, and it's because of the genetics in your family that potentially would have put your children at risk. I think I can share 2 thoughts. If in fact you or your family member is going to develop diabetes, knowledge is power, right? Knowing early allows you to prepare and think about it and be ready if that comes. Of course, it also gives you the opportunity, if there's a trial, you could do something about that. But the first thing is really the recognition that knowledge is power for many people. Secondly, that TrialNet will offer you support. You'll be talking to people who have been working with families for decades. Many of people within TrialNet themselves have diabetes. They really understand the impact of these difficult kind of conversations. We'll expect most people are going to be pretty upset if they hear that their child has multiple antibodies, but we're here for you to offer you help through that process. And the third thing I would just let you know about, there's been research that's done where there's one child in the family with diabetes, and the parents want to protect the other child, right? And not have them get worried about it. They don't want them tested because they think the child would worry. There's a lot of research, not just in diabetes, but in other chronic diseases of childhood, that the other kid is thinking about that all the time. So here's the opportunity potentially to reassure that other child if in fact their antibodies are negative. So
Great.
that was a little bit more again than you asked for, but
No, you are being wonderful in the answer, because these are not simple answers. They are nuanced and complex. So we have another question. You've talked to us about immediate family members being participants or being sought after. What about half siblings?
again, they're considered second degree relatives. So if they're up to age 20, right? So we don't screen if their half siblings are older. So why is that? Well, just in your mind's eye, imagine the person with diabetes is in the center of the circle. And the further you get from that circle, the risk is less. So if you're an immediate family member, a full sibling, actually a twin, you're much higher risk. And as you go out, as the genes are slightly different, the risk is less. And so we screen less people.
But are first cousins still part of that second layer of families?
Yes, they're second degree relatives. Yes.
So, okay, very good.
Yeah.
So we have a question, where can I get tested for antibodies through TrialNet? And you did steer us to the website, and I posted in the chat the exact page where people could sign up. But is that anywhere in the United States? Is it Canada? If I live in the United Kingdom or Australia, sort of what's the global reach for families who want to participate?
Yeah, that's a great question, because it's kind of been an evolving story over the last several years. For sure, the online testing and everything is available in the US. In Canada, you will have the opportunity, if you sign up through the website, your information can be shared with the clinicians in the Canadian territories and locations, and we'll find you a place to go get your blood draw. And again, the blood can be drawn at multiple locations. So even if you're not living next to a TrialNet site in the US or Canada, and you choose not to do any home testing, you can get that done. As far as our international partners, currently Australia has been standing up their own screening program in conjunction with TrialNet. So they have some new systems that they're working on at the moment. But again, you can get some information if you want to, through the TrialNet website, if you want to ask us, we can give you more details about Australia. Similarly, in Europe, there are ongoing screening activities in many countries in Europe. And again, they're partnering with TrialNet, but they're no longer getting screened through TrialNet. They're having their own screening activities. There are also screening programs that are being set up at many other countries in the world that are different than TrialNet.
So
But
these,
if you, I'm sorry, but if you
these
are
other,
identified as having antibodies in some of the other locations for which we do have a trial, you could still participate. It doesn't mean every place. So if you were screened in Qatar, we are not doing trials in Qatar, for example.
I see, I see. I have a couple other questions that have popped in.
Okay.
Is TrialNet involved in tracking the data around COVID potentially triggering increased diagnosis of type 1 diabetes?
Great question. And the answer is absolutely. So we are, for everybody who's participating in TrialNet, we do have a regular series of questions. We're asking whether they or one of their family members or contacts, have been impacted by COVID. Now, the good news to date, there's hardly been any. So we don't have any hint yet that there's any impact of COVID in terms of taking people who have antibodies and having that accelerated progression. But we're looking at that carefully.
Very interesting. Another question. So for people who are notified about being autoantibody positive, how are they notified about potential treatments and trials that they might be eligible to participate in?
Well, I hope, and if it's not working, I want to know about this for sure. Your TrialNet Clinical Center should be in touch with you and explain to you what all the open options are. And it may be, for example, if you, were identified as being antibody positive and we didn't have a trial for you then, by continue to participate in monitoring, we would let you know every time there's something that you're eligible for. So I do, listen, we're a big organization with a lot of dedicated people. COVID's been challenging for everybody.
Mm-hmm.
So if you feel or your family member is slipping through the cracks, please contact us. You can do it right through the website, and we'll just make sure that you didn't get dropped in getting that information you need.
Very good. And I would add just my perspective. Our family has been involved in the type 1 community for 33 years, or 31 years. That's how long my daughter, Marissa, has had type 1. And at our conferences, our Friends for Life events, TrialNet has been a participant, bringing a crack team of phlebotomists to draw blood, and people can participate. And I get on stage in front of our thousands of people, and I remind them that all the money in the world and all the great scientists in the world, like you and your partners, can't make a difference here if we, the community living with type 1, don't participate. So we all want to see a day when no one else gets type 1 diabetes. So we have to be there for you so that you can do this great work.
It's all a partnership. We're all in this together.
Indeed.
Yeah.
All right. Are there any other questions from our audience? I'm not seeing any. So let me just extend our great thanks to you, Carla. We've known each other for a long time. You gave a great presentation. Thank you so much for sharing the great work of TrialNet and for being part of that. And for our audience, our next chat is on January 31st. Dr. Rayhan Lal and the CWD team will be presenting an informative discussion about diabetes and the COVID-19 pandemic. including vaccines, new strains, and continued social distancing that we're all kind of tired of, but need to continue. You can
Absolutely.
register at cwd.is/Screenside. So Carla, I see the sunlight is beginning to fade.
Okay.
And it's already quite dark here in the Cincinnati area. So with that,
Okay.
thank you all for joining us. Have a good evening.
Thank you very much. Bye-bye now.
Bye-bye.